talk about this very important topic, are side effects predictive of efficacy? Well, when we look at the literature, it appears easily answered because several retrospective studies, in fact, have identified specific side effects to be strongly associated with outcome. This is a most recently published analysis from Murine, clearly indicating that patients who experience hypertension during treatment with sunitinib survive considerably longer than those who do not experience hypertension during sunitinib treatment. Similar results have been published by our own group with regard to hypothyroidism. We studied the effect of an increase of TSH of subclinical hypothyroidism on the outcome in patients who were treated either with sunitinib or sorafenib. And we could observe that an increase of TSH within the first 2 months of treatment was an independent predictor of survival in our patient population. So this is a summary of several analyses that were published in the last years. And what you can observe, it's mostly hypertension and hypothyroidism that were shown to be associated with an improved outcome in most analyses, even with overall survival, not only with objective response rate or with progression-free survival. And all drugs were agents that strongly inhibit the VEGFR pathway. Additional toxicities were shown to correlate with outcome. This is myelotoxicity, hand-foot syndrome, fatigue, and asthenia. However, when we look at the data available, we can clearly see that these types of toxicities are in fact less often associated with outcome when we compare this with the multiple results that we have with hypertension and hypothyroidism. So one might argue, what is more important? If you ask Murine what is more important, he would stand up immediately. Brian, are you here? And he would say hypertension, of course, is much more important. If you ask people who are more dedicated to the research on hypothyroidism, you would immediately have the answer. Hypothyroidism is, of course, much more predictable and much more predictive for outcome. I believe that we cannot separate those two side effects. We should consider that hypothyroidism and hypertension are, from a physiological point of view, strongly interlinked. Let's look at the effect of the T3 hormone on the vascular smooth muscle cell, which is responsible for relaxation. And hypothyroidism here was clearly shown to increase systemic vascular resistance and to lead to an endothelial dysfunction due to reduced nitric oxide availability. So hypertension and hypothyroidism due to this effect may occur simultaneously. What is the biological basis for the correlation of toxicity and outcome? The toxicity that we observe in our patient may reflect that the mechanism of action is appropriate in the individual tumor or individual patient. It might also reflect that the chosen drug has a high selectivity and the adequate potency to hit the relevant target, and that the tumor, in fact, is addicted to this target. What do I mean by high selectivity and potency of a drug? Well, just as an example, when we look at the potency of the different VEGFR inhibitors to reach the IC50, we can see that, for example, tivozanib is an agent where you only need very few amount of the drug to successfully inhibit the VEGFR-mediated signaling and to reach the IC50. And this relative potency on the molecular level appears to translate into efficacy in terms of progression-free survival and in terms of response rate. And the relative potency of the drug also appears to translate into outcome-relevant toxicities such as hypertension. What else is the biological basis for correlation of toxicity and outcome? The toxicity may also just reflect that the drug exposure is appropriate in the individual patient, or it might reflect the presence or absence of specific single nucleotide polymorphisms that influence pharmacokinetic and pharmacodynamic processes. So which type of side effect should we kind of welcome in our patient? I would say side effects that are attributable to the desired mechanism, which in our case, in the case of treating kidney cancer patient, is inhibition of vascular endothelial growth factor signaling. I would call this on-target toxicities, such as hypertension, proteinuria, wound healing disturbances. Of course, we are not so happy if we see side effects that are not really attributable to the mechanism of the drug, the so-called off-target toxicities, such as toxicities that may arise due to inhibition of FLT3, RAF, etc. We have to be careful here when we distinguish between on and off-target toxicities, because we have to consider that the exact mechanism of every side effect with regard to the relevant target involved is, in most cases, poorly understood. What are the clinical implications when we regard toxicities of biomarkers for successful treatment? Should we treat our patient to toxicity? Should we treat the toxicity? And what is the role of drugs that we may give our patients against the toxicity? Let me start with the first question. Should we treat the toxicity? I would like to share with you the case of a patient of mine. He's a physician. He was 48 years old when he was diagnosed with kidney cancer. Since 2009, he had complained of fever and cough and night sweats. In December 2010, he was finally diagnosed with renal cell cancer with lung and lymph node metastasis. He underwent nephrectomy and lymphadenectomy. In October 2010, we started treating him with sunitinib, classical dose, 50 milligrams, 4 weeks on, 2 weeks off. And he reported during his visits that during the 2 weeks when he was off treatment, that the night sweats were coming back. He had no side effects at all, and he had also no changes at the CT scans. So this is when we decided to change the schedule to 50 milligram continuously, and then only he developed grade 2 hypertension. He also achieved partial remission, and then he was he was referred to surgery and had a sleeve lobectomy of the right lung and radical lymphadenectomy. He continued sunitinib after surgery because he had remaining lymph node metastasis in the retroperitoneum. And then after a while he had to stop his antihypertensive medication because of hypotension. In September 2011 he progressed on the lymph nodes. This is when we increased the dose of sunitinib to 75 milligrams on a 7 days on, 2 days off schedule. And then he again developed hypertension. And this is the CT scan when he was still on 50 milligram without hypertension, and when we had increased the dose to 75 milligram, where he again had as a first symptom hypertension. Should we treat the toxicity? Well, this question is easily answered when we look at hypothyroidism. Hypothyroidism, in fact, has been proven to be an advantage rather than a side effect, because a relationship between hypothyroidism and outcome has been repeatedly observed. Thyroid hormones were shown to induce tumor cells. In contrast, hypothyroidism was shown to inhibit the growth of lung cancer cells, prostate, different types of tumor cells, to inhibit neoangiogenesis. And in patients with head and neck cancer, hypothyroidism was associated with an improved outcome. This is an MRI from a patient from Cleveland who had an end-stage glioblastoma, no more drugs left for treating this glioblastoma. And the colleagues there just chemically induced hypothyroidism and achieved a quite impressive response. So the data suggests that hypothyroidism should be tolerated as a toxicity in order that we get a better oncological outcome, but be aware here we have really to consider the several detrimental effects of hypothyroidism on our cardiovascular system, like abnormalities of myocardial relaxation, LVF impairment, increase in blood pressure, impaired endothelial function, and so on. So my personal view here is we should tolerate hypothyroidism on a very individual basis to some extent. But of course, we have to take care of those cardiovascular consequences. The last question, and it might appear a little bit ridiculous to discuss this topic, but I think it's important. What is the role of drugs given against the toxicity for the oncological outcome? Can we totally rule out that treatment, for example, of hypertension, rather than the ability to induce hypertension, is responsible for improved outcome? I don't think that we can rule this out completely, because all of you have treated your patients who showed up with hypertension. I don't think that you have left your patients with increased blood pressure. And what is the impact of those drugs on the tumor? Beta blockers, for example, were shown to induce apoptosis in endothelial cells. Beta blockers have been established as a standard of care in patients with infantile hemangiomas. Several reports have demonstrated, interestingly, that angiotensin 2 stimulates the growth and migration of certain cancer cell lines and induces angiogenesis through upregulation of vascular endothelial growth factor. And this effect can be inhibited by angiotensin receptor blockers, all agents that you are certainly using in your patients. Losartan, for example, was shown to stimulate the pro-apoptotic signaling pathway regardless of p53 mutation in pancreatic tumors. And similar results have been achieved in various tumor types. Calcium channel blockers were shown to reduce the proliferation and migration of glioma cells. This is a figure that illustrates the impact of an angiotensin 2 receptor antagonist on an osteosarcoma model. And what you can see here, that the ability to reduce the tumor weight appears quite impressive. So to summarize, side effects appear to be predictive of efficacy. However, the results have to be interpreted with caution, because the assessment of side effect was different in the different analyses. Prophylactic measures may certainly confound the results. The findings, of course, do require validation in prospective trials. Therapeutic concepts arising from these findings, such as treat to hypertension or tolerate hypothyroidism, also require prospective investigation. We shouldn't underestimate potential benefits arising from co-medications that we provide against side effects. And to conclude, none of these markers is ideal, because the ideal predictive marker is evaluable before treatment rather than during the treatment. Thank you very much for your attention.